Hello, my fellow future and curious little rats out there. Welcome to the Lab Rat channel. My name is Squeak. This week I actually decided to talk about collection methods for blood and the different tubes and the general problems that we have in the lab with all of these things. So what I'll start off talking about is the two different types of needles that we use. There is the one that we call or refer to as the straight needle, and it's the long one that you will see us use. The other one is what we call a butterfly needle, and it got its name because it's got two little plastic wings that we grab a hold of, and it's a little needle, it's a short one, and it's got tubing that's about 12 inches long. So with these two different types of needles, there's really, aside from the length and the tubing, not much difference between them. They come in the same sizes. So after the needle, there is the hub or connection for where we can put the tubes on. With the most known or commonly used method, there is what we call the hub or the vacuum holder, and it's a plastic cylinder that either one of those needles screw into. And there's also one that nurses can use to hook to your IV port, and it just screws right on there, and it serves them the same purpose that it serves us. And then there's the syringe method, which this is where a lot of people have problems collecting, because most people that haven't been trained in proper phlebotomy techniques, when they hook that syringe up, they pull straight back on the plunger as far as it'll go, and they slowly have blood going in there because the vein can only keep up with so much vacuum. And most of the time this ends up causing redraws, because as the blood is going past the bevel on the needle, because it's under such high vacuum, it shreds the red cells, thusly causing hemolyzed blood. When this happens, we cannot run chemistries on it because it falsely elevates your electrolytes along with a few other things. We can't do hematology off of it because part of the hematology, or CBC, complete blood cell count, is your red cells, and if they're shredded, you're not going to get an accurate count. The other thing that this will mess up is blood bank, because one of the reactions we look for is hemolysis. If your blood has a reaction to certain antibodies, then it's going to hemolyze, and that's what we look for as part of the readings. If it's hemolyzed, we can't give it to you. So when drawing from a syringe, you just pull back a little bit, wait for it to release, and keep slowly pulling back. This way you don't get hemolyzed blood. Then you need to get it into the tubes as quickly as possible before it starts to clot. And part of this, you also have to get the tubes inverted so that the additives get mixed in with the whole blood to prevent it from clotting in most situations. There are a couple tubes that we have that we do want to clot. We fully expect them to clot. So when it comes to tubes, there's whole blood tubes, which is going to be a lavender, that's the purple top. There is the pink, speaks for itself. It's a baby pink top in most situations. There's also a pearl pink, which is a really light pink, and it does have a pearlescent type lid on it. There's also, so those three are the ones we mostly use for hematology. The lavender / purple one is what we use on our complete blood cell count analyzers. We also use them for ESR, erythrocyte segmentation rate. Can also be used in blood bank. Some facilities, that's all they use for a blood bank is these short little purple/lavender top tubes. Most places prefer the pink top, which is a little bit bigger. And again, it's got to be whole blood, can't have any clots in it. And then the pearlescent pink top is used for specialty whole blood stuff. And most of the time that's going to be like hepatitis titers and other types of titers. And those get sent out to specialty labs, so I really don't know too much on those or how they're ran. Next, for whole blood, is blue top. The blue top tubes are used on coagulation. Again, they have to be whole blood. We can't have any clots in there because if they clot it up, we will not get a accurate prothrombin time, PTINR, as most people know it. There's a few other coagulation studies that are done off of these tubes, like there's one where they see how your platelets react, behave, see if they're reacting. There's a few different tests, but these are all coagulation. Blue is coagulation only. It cannot be used for anything else. The next thing is green top tubes. These are what we call plasma tubes. These ones, again, cannot be clotted. The difference between plasma and serum is plasma still has the platelets, fibrinogen, other clotting factors still loose in what we call the supernate, which is when we spin down the specimens, you've got your red cells that go to the bottom of the tube, and then you have your serum and or plasma that sits on top. This is what we run tests off of for chemistries. And with these, so there's the green tops. All of your green tops are going to be plasma because they still have, as I said, the clotting factors mixed up in that supernate. Then we have red tops, tiger tops, which are red and black, just kind of swirled. There are gold tops, and some of these red, tiger, and gold tops will have what I refer to as the goober in the bottom. It's a gel separator. All the red cells, when you're centrifuging or spinning it down, will go down through this gel separator, and then the serum sits on top. The serum is lacking the clotting factors. It has no platelets in it. It has no fibrinogen in it. Analyzers, we get a cleaner reading off of this because there's not as much, I guess you could call it, background noise in the fluid that we are testing. So with these ones, they have to clot. On average, you need to let them sit for 30 minutes. Especially, there's some that have a clotting activator in them that helps them set up and clot quicker. And then there's some red top tubes that have nothing in them. It's just a plain plastic tube, and you have to let those sit for an hour. That's how long it takes on average for a normal person's blood to solidify or clot. In order to get accurate readings, we need to have all of these tubes drawn in the appropriate order of draw, and I will post a link down below in the description where you can go to look at the order of draw, because some of the additives in some of these tubes counteract the additives in other tubes, and we can't have them cross-contaminated because, again, it's going to counteract what the next tube is supposed to do, and we will get a bogus reading. Then we're going to be calling for a redraw on the patient, which means the patient's going to have to get stuck again And we don't want to spend all of our time poking our patients. Just do it right the first time. Make sure you know what you're doing the first time so that we don't have to go back and stick them again. Nobody likes that. One of the other ones that we get a lot of funny calls about is blood cultures. We cannot do a blood culture off of a finger stick. It doesn't work that way. These are sealed tubes. We cannot open them. It's not like your normal tube where if you have to, you can pop the top off and drop blood in there. No. They are sealed tubes. They are sealed for a reason. It's to keep contaminants from getting in them. When we draw blood cultures, as we set the patient, as we prep the site for drawing blood cultures, we will use either iodine, betadine, or chloroprep. These three things kill all the bacteria that is on the skin surface. We draw normally 2 sets of cultures from 2 different sites. The reason why we draw multiple sets from different sites is because it's a double check for us to make sure that if something's growing in the bottles, that same thing grows in both sets in the appropriate bottles. If it only grows in one bottle, it's what we call a skin contaminant. And both sets are then thrown out, unless of course something else does grow that's in both sets. But again, if you only get one bottle that goes, it's a skin contaminant. It got messed up upon drawing. Drawing blood cultures and stuff on pediatrics, that's a lot harder because there's only so much blood that you can take out of somebody, whether they're baby or adult, within a certain amount of time. Again, I'll post a link down below to a chart that was posted by, if I remember correctly, Chicago Pediatrics or something like that. It'll be in the link down below so you can look at it. When it comes to the pediatrics and the babies, we normally do what's referred to as a heel stick to collect blood on them, and we use what's called bullet tubes. These tubes come in the lavender, the green, there's a yellow, and I think there might still be a red. I'm not too sure if they still make those or not. They no longer make the pediatric sized coagulation tubes, unfortunately, because that would save us a lot of problems, especially with the elderly, which we normally can't get a lot of blood out of. But what we do is we just have these tiny little tubes that take 1 to 2 cc's at most for each tube, and we don't even put that much in them. We put 0.2 in each tube, and that's more than enough. But we will use a lancet and clean off the bottom of the baby's foot, poke them with that lancet, and then we will just what's called milking and get the blood in the tube. Again, make sure your lavender's shaken up. Shake the snot out of it. That way it doesn't clot, because you don't want to have to go back and poke that baby again. Makes you feel bad, pisses off the parents. I've been on the receiving end of that before, where I've had to go and recollect after one of my coworkers didn't shake up the lavender top tube, and they were some very upset, pissed off parents. And I don't blame them. Should have done it right the first time. But with blood cultures with peds, normally what we'll do is we'll have a second person from the lab come with us. We use a itty bitty tiny 25 gauge butterfly because it's such a small needle, and we normally go in one of the veins on the back of the hand because that's the easily accessible veins, especially on newborns. Some of your older kids that are like 5 months old and older, by that time the veins in what we call the AC, which is right here in the crook of the arm, are a lot easier accessible by that time. They've plumped up a little bit. But we will prep the back of their hand. We'll have a second person hold to make sure that they don't move. And we will use a syringe. And thankfully with pediatric blood culture bottles, they are their own separate tube that take at most 5 cc's. So there are special blood culture bottles for pediatrics. Another thing that most people don't know is if you have an IV, you can get your nurse to draw from it. Don't let them fight you on this. We don't have to come in and punch another hole in you to collect your blood. It's not necessary. If you've got a good working IV, the nurse can go in there, use a saline flush, and they disconnect your IV if you're receiving medication or antivirals or anything like that. Any form of IV drip, pretty much. They disconnect it, wait 15 minutes, then they can go back in, flush your IV with 5 cc's of NS or whatever they're using, wait a couple minutes, and then they can take that screw-on vacutainer that I was talking about and they can pop it right on there. And then we recommend that they either waste 15 cc's, yes, 15, it's a pretty sizable syringe, or what they can do is they can take a large red top tube, pop that on there, and then throw that away. Then perform correct order of draw, make sure they invert the tubes, like I said, so that we don't have to come back and draw you again. Because if they screw up the draw and we end up with that clotted tube, you will see somebody from the lab come in to draw you, so that way we make sure it gets done right the second time. But after they draw you, then they'll flush your site again, make sure everything's okay, hook you back up to your IV, and then you're good to go. Another issue that we have on the phlebotomy side with drawing is fasting lipid panels. Just so you know, when your doctor tells you that they want you fasting, you can drink all the water you want. Continue drinking water. It makes life easier on everybody, and it's not going to mess with your fasting results. It's just water. It'll keep you hydrated. It'll make your veins easier to get. Makes life easier for everybody involved. So keep drinking water. Some facilities will allow the rule of you're allowed 1 4-ounce black coffee, no sugar, no cream. Some facilities won't allow it. So if you know where you're going to go have your blood drawn when your physician wants lab work done, call them the day before and see if your orders are already there, and ask them if there's any special prep that you need to do. Again, ask them if there's any fasting that you need to do, and if so, if you're allowed to have that coffee if you want, or just drink water. The facility will know. Each facility has their own separate rules on whether or not they allow certain things. So just call them and ask them. We're more than willing to answer questions. We're happy to educate, at least most of us are. So hopefully this covers a lot of questions that some nurses or doctors may have about why we reject samples. Hopefully this answers some questions to some patients on why we've had to recollect specimens. And until next week, may you have a wonderful week because you choose to have a wonderful week. And I'll see you all later. Bye.